So, Assalamu alaikum, good afternoon. The journal I'll be presenting this afternoon is from Pediatric Critical Care Medicine of October 2021, entitled Driving Pressure is Associated with Outcome in Pediatric Acute Respiratory Failure. But before I discuss about the journal, I would just like to discuss a little about what driving pressure is. So driving pressure, so in a ventilated patient without spontaneous breathing effort, like those patients sedated and paralyzed and on controlled mechanical ventilation, driving pressure of the respiratory system is defined as the difference between the plateau pressure minus PEEP, and also it is the ratio of tidal volume to the respiratory system compliance. So the driving pressure, it is a physiological way of adjusting the tidal volume to the residual lung size. So it represents the tidal volume corrected for the patient's respiratory system compliance, and static compliance of the respiratory system. It is the compliance measured during periods without gas flow. So I will just show you this illustration. In this illustration, where the driving pressure of the patient in a ventilated in volume control mode. So what the clinician can control or can manipulate will be the PEEP and the tidal volume. So this is the independent variable, while the dependent variable will be the plateau pressure, which your monitor will give this. It's a system output, and your compliance of the respiratory system. This is a derived variable that forms the slope of the change in your tidal volume over your change in your pressure relationship. So regarding the driving pressure, so after the description of the baby lung concept, which revealed that physiologically small lungs in patients with ERDS. So a lot of studies were done to test the hypothesis of limiting the tidal volume or airway pressure might improve the outcome of these patients with ARDS. So the significance of the driving pressure, it was first highlighted by Amato and colleague in a study published in a New England Journal of Medicine this is 1998, where they concluded that the lower driving pressure were independently associated with better outcome. Then came the trial about the large multi-center ARDS network trial, where they it showed that there is a decrease in mortality when a low tidal volume was used compared with what is this, limiting the tidal volume. So this is where we started the lung protective strategy with the lower tidal volume, also the use of lower plateau pressure and higher PEEP. Then there were studies done, and trials have found out conflicting responses in whenever they manipulate one of these variables, like manipulating the tidal volume, optimizing it would negatively affect the other variables. So again, Amato et al. Did another study in 2015. This is again in New England Journal of Medicine. And here they based, this study was based on the baby lung concept, in where the compliance or static compliance of the respiratory system is linearly related to the amount of the inflictable lung volume. So here they hypothesized that the driving pressure would better correlate with the survival than that of the tidal volume and the PEEP. So this here in this study, actually, the 3,500 patient in this study was already enrolled in a previous 9 studies done for ARDS. And here they show that the higher driving pressure was associated with increased mortality, and that reducing the driving pressure by limiting the plateau and increasing the PEEP was associated with increased survival. I will just show you this illustration because the journal that I will be discussing, they were inspired to do their study because of this study done by Amato, and also they mirrored the same methodology. So here, as you can see, they did multi-level mediation analysis. So they matched the same PEEP. Another group matched with the same driving pressure, and also matched with the plateau pressure. So here, as you can see, if your PEEP is the same, your driving pressure is increasing, and so your plateau pressure. And also they noted that with the increasing in the plateau pressure, there is also an increase in your mortality. And in the next group where they match the driving pressure, the plateau pressure was rising, and so is your PEEP. But here, the mortality was the same. And in the last group here, where they matched the plateau pressure, they noted that with the same plateau pressure, the PEEP was increasing, but the driving pressure was decreasing. And so the mortality was also decreasing. So in this journal, the driving pressure is associated with outcome in pediatric acute respiratory failure. Their objective was that the driving pressure is associated with mortality in acute respiratory distress syndrome, and they sought to evaluate if such association could be identified in critically ill children. So to study if there was an association between the driving pressure and ventilator-free days at day 28 in a heterogeneous group of mechanically ventilated children after stratification for disease category proposed by the Pediatric Mechanical Ventilation Consensus Conference. And also to test the agreement between driving pressure calculated by the ratio of your tidal volume over your respiratory system static compliance versus plateau pressure minus PEEP, which is your static pressure gradient, or your PIP minus PEEP, your dynamic pressure gradient. So here, the study was designed as a secondary analysis of routinely prospectively collected demographic, physiologic, and laboratory data from sedated or paralyzed patients in children less than 18 years of age without with and without lung injury on weekdays at 8 a.m. So they would collect data every day during weekdays at 8 a.m. And data from the patients excluded were those who had congenital or acquired heart disease, those with obstructive airway disease, those with documented lung diseases, neuromuscular disorders, severe traumatic injury with Glasgow Coma score of less than 8, chronic lung disease, severe pulmonary hypertension, managed with high frequency, and also with an endotracheal tube leakage greater than 18%. They also excluded patients if the chronological age reduced by the number of weekdays born before 40 weeks of gestation was less than 0. And the severity of the disease was assessed by a 24-hour pediatric risk mortality. And the PIMVEC definition was used to stratify the patient based on their admission diagnosis. And pediatric ARDS was identified using the Pediatric Acute Lung Injury Consensus Conference, the PALISI definition. So here, in their institution, they were ventilating patients in a pressure control mode of ventilation, and they limit the inspiratory pressure less than or equal to 28 centimeters water. Also, the expiratory tidal volume was around 5 to 7 ml of kilogram of actual body weight. And they mentioned that they only used cuff ET tube. And setting the ventilatory breath rate, this is dictated by the underlying pathology and age. Also, they made sure that they monitor the flow time scalar and that there is no development of intrinsic PEEP. And here, the initial PEEP is around 4 to 6 centimeters water, and it is titrated according to the discretion of the attending physician. They target transcutaneous oxygen saturation of 88 to 92%, and also target pH greater than 7.2. The ET cuff was inflated prior to the measurement to prevent air leak. So they measure the plateau pressure and static compliance at the end of inspiration by a manual inspiratory hold manual maneuver of 3 seconds. So for the data analysis, to assess the oxygenation, they calculated the mean the oxygenation index or the oxygen saturation index. They also calculated the ventilator-free days through day 28, which is defined as the number of days within 28 days that a subject is alive and free of mechanical ventilation. And they calculated the driving pressure by the ratio of the tidal volume over the respiratory compliance, respiratory system compliance, and dynamic pressure gradient was calculated by the PIP minus PEEP, and the static pressure gradient as plateau pressure minus PEEP. And here they group the patient as ventilated for direct pulmonary indication if they met the PIMVEC clinical phenotype criteria for restrictive and mixed lung diseases, and patients with normal lung mechanics as ventilated for the indirect indications. So what they mean here is that with the PIMVEC consensus conference, the disease definition was based on the respiratory physiology. So for the restrictive respiratory disease, this is with the respiratory physiology of reduced lung compliance or reduced chest wall compliance and with normal airway resistance. So example of this are patients having ARDS, pneumonia, or those with pulmonary contusion. And for the mixed diseases, this one with reduced lung compliance and chest wall compliance, and also with increased peripheral airway resistance resulting in airflow limitation. So under this would be, example of this would be your patient with status asthmaticus due to acute, and also with those patients having, these patients having both CO2 retention and hypoxia secondary to acute lung injury or viral bronchiolitis or pneumonia. And for the patients for the indirect pulmonary indication, this is with the normal lung mechanics. So these patients, they have the normal compliance and normal resistance, but they have the loss of respiratory drive. So example of these are those patients who went to who underwent surgery or electively ventilated, or those patients with ventilated for the depression of your respiratory drive or neuromuscular disorder. And for the statistical analysis, they used that for the normality of data. It was assessed using the Kolmogorov-Smirnov test. A continuous data was presented as median and interquartile range. And also analyzed by the Mann-Whitney U for comparing two groups. Spearman correlation coefficient was calculated to analyze the correlations, and chi-square test with Yates continuity correction was used to analyze categorical data. So the primary outcome measure was the ventilator-free day 28, and mirroring the study of Amato, they wanted to study if the driving pressure would provide prognostic information independent of plateau pressure or the PEEP. So they did a double stratification resampling, producing subgroup of patients with matched mean levels of one variable, but distinct mean values of another ranking variable. So for the results, this is a data of 222 mechanically ventilated patients, and the median age of this is 11 months, and 119 of these patients were younger than 12 months old. So most of the patients were infants. And the primary admission diagnosis was respiratory failure. This the direct pulmonary indication, those patients having the restrictive and the mixed respiratory system, a total of 143. And 65 of these met the PIMVEC clinical phenotype criteria for restrictive, while for the mixed respiratory system, 78. And 10% of the patients met the ARDS criteria for the ARDS criteria from the PALISI criteria for the ARDS. And the duration of the mechanical ventilation was 95 hours, and 9 patients died. So here you can see that for the acute respiratory distress syndrome, so 4 from the restrictive and 19 from the mixed respiratory system mechanics. The static compliance was lower in the mixed respiratory system group. PIP was also higher in the mixed respiratory system group. More or less, it was the same for the normal and the restrictive. Plateau pressure was also higher in those patients with the mixed respiratory system mechanics. And the PEEP was more or less the same in the old age from 5 to 6. Also, the tidal expiratory tidal volume was more or less with 6.6 in mixed, and this more or less the same for normal and restrictive. Also, the oxygenation index was in the lower side. So when they analyze the driving pressure for the whole cohort, the driving pressure for the whole cohort was 16 centimeters water, and the driving pressure correlated significantly with plateau pressure and PEEP, but not statistically significant with the tidal volume. Also, the driving pressure significantly correlated with the static pressure gradient and the dynamic pressure gradient. Here, this is a blunt outline plot with the level of agreement between the driving pressure calculated as the tidal volume over your respiratory compliance, and also tidal volume calculated versus calculated with your plateau pressure minus your PEEP, which is your static, and also driving pressure calculated as the tidal volume over your respiratory compliance versus the dynamic, the PIP minus PEEP. So the average bias between the driving pressure and dynamic pressure gradient was negative 0.092 plus 3.1 and 2.49 plus or minus 2.44 for the static pressure gradient. So as you can see here, this is the upper limit of your agreement, and this is the lower limit of the agreement. And here, based on this figure, they stated that the dynamic pressure was overestimated the driving pressure. And a patient who met the pediatric ARDS criteria had significantly higher driving pressure. And the driving pressure was significantly higher among patients subsequently managed with high frequency during the PICU admission. So the driving pressure when the analysis with the PIMVEC clinical phenotype. So patient meeting the criteria for the clinical phenotype of normal lung mechanics had the lowest driving pressure, and a patient with mixed lung mechanics showed the highest driving pressure. And those patients who were ventilated for indirect pulmonary indication had a significantly lower driving pressure. These are those with the normal lung mechanics. So they both showed that low driving pressure. Here, this figure, graphically describe the ventilator-free day 28 in mechanically ventilated for direct and indirect pulmonary indication matched by PEEP, by your driving pressure and your plateau pressure. So here, if you notice, this will be the PEEP, the black one, the gray will be your driving pressure, and this will be your plateau pressure. So here, as you can see, the plateau pressure increased significantly in all the samples, while the driving pressure significantly increased when it is matched for PEEP. So here with the same mean PEEP, you will see that the driving pressure was increasing. And the driving pressure was decreased when it was matched for the plateau pressure here. It was also observed that there was a significant decrease in your ventilator-free day here if when there was an increase in the driving pressure here in this group with in patient with ventilated or for direct pulmonary indications, those having mixed and restrictive lung diseases. So with this, there was a significant decrease of your ventilator-free day 28. And there was no relationship in group of a match for your PEEP and plateau. Only they noted significant decrease in the ventilator-free days for those having the increase in driving pressure with matched PEEP for the ventilated for direct pulmonary indication. Here, they observe that this will be their driving pressure, and here will be your ventilator-free day. And they noticed that there was a significant difference when the driving pressure was grouped at 15 centimeters water. So they observed that there was a statistical significant difference in ventilator-free days between the four stratum of this patient. So those with lower driving pressure had higher ventilator-free days, and those above 15 had lower ventilator-free days. So for the discussion, the main finding was that the higher driving pressure was significantly associated with an increase in time to extubation after adjusting for the severity of the disease and mechanical ventilation indication, and also that the dynamic airway pressure gradient overestimated the driving pressure. They also found an increased time to extubation was associated with increasing driving pressure after adjusting for disease severity and presence of a direct pulmonary ventilation indication. But in this study, they could not detect casualty. And also they tried to points to consider between the difference of doing the driving pressure among adults and in pediatrics, because the concept of the driving pressure was this was derived from an adult ARDS, where in adult they usually use the volume control mode of ventilation, wherein they select that tidal volume in range of 5 to 7 ml per kilogram of predicted body weight. So it was easier for them to calculate at bedside the driving pressure. While in pediatrics, the predominant mode of ventilation is the pressure control mode, wherein the clinician limits the inspiratory pressure and the delivered tidal volume is dictated by your compliance of your respiratory system. So it could also be stated that the concept of driving pressure is already being taken into account, but although it was not consciously done. And also they had this idea, Amato et al. Stated the idea of improving the outcome by limiting the driving pressure, which can be achieved by increasing your PEEP. But in PICU, usually the practitioners, they tend to use low levels of PEEP and accepting higher FiO2. So It may therefore be surmised that better PEEP strategies are required to make the limiting driving pressure as a concept that might be adapted into pediatric critical care. But at present, there is no pediatric randomized controlled trial showing that higher PEEP improve patient outcome. For the limitation of the study, this designed as a single center study that may limit the generalizability of the findings. Also, most of the patients included in this study were infants, so it would have been better if older children were included. Also, the driving pressure was for the ARDS patients, but in this one, there was small number of patients having the ARDS. Second one is the liberal use of the high frequency mode of ventilation. It might have impacted the total ventilation time, thus the primary outcome measure. And they grouped the patient by the PIMVEC criteria using the admission diagnosis and not the baseline compliance of the respiratory system, so potentially leading to incorrect labeling. Also, esophageal pressure measurements, which could be a surrogate for your pleural pressure, was not implemented, so they could not ascertain the effect of the altered chest wall mechanics in the cohort. Also, the auto-PEEP was not measured. So in conclusion, higher driving pressure was independently associated with an increased time to extubation, and the dynamic airway pressure gradient overestimated the driving pressure. So future studies are required to understand if driving pressure is a determinant or marker of severity in pediatric acute respiratory failure. Injurious threshold for driving pressure in patient with or at risk of pediatric ARDS need to be identified. So this is the end of my presentation, and these are the references. Any questions?